On behalf of the Balm in Gilead, thank you for virtually attending the Healthy Church's 2030 National Conference and being a part of this institute. Before the presentation begins, here are a few things you should know. This session is one of two live 90-minute concurrent sessions. Both sessions will be recorded and available on demand through the platform for this conference. This typically occurs within 24 hours, so you can look for the on-demand link for this session on the Agenda tab. All registered attendees will have access to the Healthy Church's 2030 conference platform and session materials for 1 full year. Please take a moment to fill out the session evaluation survey. This survey link is posted on the program page for this session, and we will post the survey link in the chat right now and towards the end of this session. Now, here's the facilitator for COVID-19 testing and vaccines and treatments, Dr. Pernessa Seal, who wants African Americans to know the facts.
Well, hello, and thank you for joining this very important symposium institute COVID-19 testing, vaccine, treatment. African Americans must get the facts. This is one of those institutes that has my heart, which is why I am actually facilitating, because as COVID-19 is raging again, raging even more in this fall winter season than it did in the springtime, we African Americans are more vulnerable than ever before. We have lost so many. Each and every one of our denominations, our churches we are grieving. We are grieving the loss of so many of our pastors, our bishops, our mothers of the church, our missionaries. The entire church has been so impacted by COVID-19, our communities, our families. And as we hear the numbers are out of control across our nation, across our world. We must get the facts, because clearly we will be the most ethnic group that will be impacted. So I am glad that you are joining us today, because we want to give you the facts. We want to give you a reality conversation about testing, about vaccines, the whole nine, because we cannot die if we don't have to die of COVID-19. COVID-19 is a preventable disease. It is a preventable disease. So we must get the facts so we can live and survive this pandemic. My panelist today is Greg Millett, the Vice President and Director of Public Policy at AMFAR in New York City, who's also my co-facilitator. Dr. Ala Sanford, MD, pediatric surgeon, and the founder of the Black Doctors COVID-19 Consortium, and Reverend Dr. Jacqueline A. Thompson, the senior pastor at Allen Temple Baptist Church in Oakland, California, and Bishop Dr. Horace Smith, the senior pastor of Apostolic Faith Church in Chicago, and the chair of the Healthy Churches Conference, and assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. We are all here because we are in the middle of a terrifying global pandemic of which African Americans and Africans are leading the charts. So I'm going to turn it over to my first speaker, Greg Millett. I'll let him introduce himself, and he has the mic. Thank you, Greg.
Great. Thank you so much, Dr. Seal, and welcome everybody to our discussion today of COVID-19, and particularly COVID-19 and its disproportionate impact in the Black community. My name is Greg Millett. I'm the Director of Public Policy at AMFAR, Foundation for AIDS Research. And prior to joining AMFAR, I was a scientist at the CDC for 13 years, who left to join the Obama White House to help provide the scientific background for President Obama's national HIV/AIDS strategy. So part of what happened with the national HIV/AIDS strategy is that we knew that African Americans were at disproportionate risk for HIV, but it's not just HIV. We're seeing the same disproportionate risk for African Americans for COVID-19. And one of the questions that we keep hearing in the media is why? So I just want to go through part of the reasons why we see this, is also provide you some data of what we have been seeing, unfortunately, in the nation. So as many of you might remember, as early as February as well as March of this year, we saw instances of greater rates of COVID-19 and greater hospitalizations of COVID-19 in different states, in different cities, among African American communities, but there were no national data that were available. And there were calls from Congress, there were calls from many different sectors for greater national data from CDC. Part of the reason that CDC didn't have the data is because they were dealing with an explosion of cases, and many of the practitioners on the local level were too busy really just trying to deal with the burgeoning caseload rather than to collect data by race and ethnicity. But there's a problem with that. And one of the biggest problems was that as late as April of this year and even early May, about 78% of the data nationally were not disaggregated by race or ethnicity for COVID-19. We had no idea what race or ethnicity most of the individuals were. So what we did, my colleagues and I, was we published a paper that got a lot of national news where we looked at those counties that were disproportionately African American in the US. And we looked at the cases of COVID-19 just to see if we would see any sort of relationship. And what we found is that Black counties in the US accounted for about 22% of all of the counties in the US. These are counties that are 13% or more African American, but they also accounted for 52% of the national COVID-19 cases and nearly 60% of deaths. And we also found that in disproportionately Black counties, there were higher rates of some of these underlying conditions, such as diabetes, cardiovascular disease, and other conditions that we know are associated with COVID-19 hospitalizations. The problem, though, is that when we actually looked at this quantitatively, that did not explain the higher rates of COVID-19 or COVID-19 deaths in Black communities. What did explain it was access to healthcare, the number of people who were in dense housing conditions, and the degree to which there was higher levels of unemployment in these disproportionately Black counties. And this is basically a graph showing exactly what we found. You could see that as a percentage of African Americans increase across counties in the US, you see an increase in diagnoses of COVID-19. And each one of these are different counties at the time where we saw high rates of COVID-19. Mind you, these are data from April 15th, so it shows just how disproportionately impacted Black Americans were as early as April 15th nationally. And one of these dots is a dot from Georgia, from Dougherty County. Y'all might remember that there were 2 funerals that took place in Albany, Georgia, in a Black community, very small county where there were 40 cases, an outbreak of over 40 cases of COVID-19. And that was one of the first times that people nationally were aware of the fact that COVID-19 was spreading rapidly in Black communities outside of urban areas like New York City. And what this looks like graphically is we put together a graphic to show those disproportionately Black counties, that's in orange, compared to all other counties in the US, so that you could see where COVID-19 cases are, as well as COVID-19 deaths. And this is going over a period of time. And this is something that got played on CNN, MSNBC, and others. And this is updated to this day. So as of November 14th, disproportionately Black counties accounted for 39% of all COVID cases in the US and 46% of deaths. Again, we are disproportionately represented still in COVID-19 cases, despite the fact that we're only about 13% of the population. And part of where we see this disproportionate impact, unfortunately, is everywhere demographically in the Black community. So we know that African Americans are more likely to have higher rates of HIV. We know that people who are living with HIV are aging with HIV in the US. The people to the left are 3 friends of mine, all over the age of 60, that were all HIV positive, who I lost to COVID-19, who our community lost to COVID-19. And we're seeing this, unfortunately, taking an impact in Black communities overall, where individuals who are over the age of 65, the highest rates of COVID-19 deaths are among African Americans. It doesn't matter if it's 65 to 74, 75 to 84, or 85 and older. The highest deaths are taking place among us. And unfortunately, when you really take a look at these data, there were data that just came out from CDC last month, which basically found that if you look among older Americans, about 1 in 300 white Americans are hospitalized with COVID-19. 1 in 120 American Indians are hospitalized with COVID-19. 1 in 110 Latinos are hospitalized with COVID-19 in the US who are older. For Black Americans, it's crazy. 1 in 87 of us who are over the age of 65 up until that date were hospitalized with COVID-19. So this is something that is really disproportionately impacting us. And unfortunately, these death rates are not just for older Americans. We see that these disproportionate impact of COVID-19 deaths is for every age group in the US. So even going down to 55 to 64 years old, or 45 to 54, even 35 to 44, the greater rates of deaths are taking place in Black communities. And unfortunately, we see the same thing too with Black and brown children. When you take a look at COVID-19 deaths, the few deaths that have taken place nationwide, the overwhelming majority of those deaths are among Black children as well as Latinx children. And you can actually see here that Black children are as much as 2.5 times more likely to die from COVID-19 compared to other populations, compared to white populations in the US. Now, the big question that we always get is why? And one thing that you hear in the media all the time is that higher levels of obesity, higher levels of cardiovascular disease, higher levels of diabetes, but that's not really explaining why we are at higher risk for COVID-19. These are maps showing where heart disease is most prevalent in those counties in the US that are disproportionately African American. And you can see that that's concentrated in the South, and that makes sense because most of the African American community in the US lives in the South. But the darker shows where the counties are that have high rates of heart disease, and then the darker here shows those counties where there are high rates of diabetes in disproportionately Black counties. The thing that the media is spending less time talking about are the social determinants of health. So that is poverty, unemployment, uninsurance, where again, you see these same counties with extremely high rates of poverty, extremely high rates of unemployment, extremely high rates of being uninsured, which is associated with greater rates of COVID-19. And it's not just COVID-19, it's associated with greater rates of many other diseases as well, from breast cancer to lead poisoning, to many other diseases where we see these same factors that are putting African Americans at higher risk for any of these diseases. Another issue that we see that's part of the COVID-19 epidemic is the fact that it's not just a COVID-19 epidemic that's disproportionately affecting Black Americans, it's the recession that is taking place with COVID-19 that's also disproportionately impacting us as well. And that has major problems when it comes to your health and impacting our health. These are data on the left-hand side from the National Institutes of Health, which basically shows that those individuals and families that are making less than $25,000 per year are 3 times more likely to die from anything as compared to families that are making over $115,000 per year. Same thing with families that are making about $33,000 per year are 2.5 times more likely to die from anything as compared to those families that are making more than $115,000 per year. So income is actually associated with health, and people who have lower income have higher rates of mortality. So what does that mean when we're looking at the economy right now, where primarily Black and Latino households are experiencing serious financial problems because of the COVID-19 pandemic? What does that mean in terms of mortality rates for us? More importantly, what does that mean when we have higher rates of unemployment taking place in the Black community as compared to all other communities in the United States, as well as a greater proportion of African Americans who are bracing for a mortgage crisis or even an eviction crisis from their homes if they're renting, as compared to all other populations. And we know that housing is also associated with COVID-19. And if people are being evicted from their homes and have to stay with family, that could also increase rates within our community. The other issue as well is Black-owned businesses. There was a study from Stanford University that found that 40% of Black-owned businesses are not expected to survive the coronavirus pandemic. You compare that 40% with white independently owned businesses, only about 17% were not expected to survive the COVID-19 pandemic. So there are real inequalities that we're seeing here. The other inequality is in terms of employment, which is placing Black communities at higher risk. We know that Black and Latino workers are more likely to be essential workers. We are less likely to have jobs that keep us at home. And it means that we're more likely to be exposed to COVID-19. In fact, there was a study that looked at the percent of households that have at least one person who cannot work remotely. And they found that those households were about 65% of Latino households, 56% of Black households have at least one person where they can't work remotely, as compared to only about 46% of white households. And we know that as we reopened the economy back in May, that it was disproportionately placing Black as well as Latino workers at greater risk for COVID-19, an explosion of COVID-19 within our communities. The other thing that is placing us at greater risk is the higher rates of community spread that's associated with COVID-19 in various institutions. So for instance, we know that as many as 8 of 10 of the largest outbreaks nationwide that were related to COVID-19 came from correctional facilities. And we know that African Americans are more likely to be unfairly incarcerated compared to all other populations in the US. And there's also very high rates of COVID-19 that are taking place in prisons. So much so that there was a study that came out of Chicago that found that in the Cook County Jail alone, because there were so many people who were cycling in and out of the Cook County Jail, that accounted for a disproportionate amount of COVID-19 cases on the outside in primarily Black and brown communities. We're unfortunately seeing the same thing with nursing homes, where those nursing homes that have a greater proportion of Black residents also have the greatest number of outbreaks for COVID-19. And part of the reason why we're seeing that is because of the staff from those nursing homes usually come from Black neighborhoods. And Black neighborhoods also have a higher background prevalence, a higher number of people who have COVID-19 and might have COVID-19 and not know it. Those staff bring it to the nursing homes have a greater number of outbreaks as compared to white nursing homes. So we see this community spread that's taking place in institutions that house a greater number of African Americans. Another issue that we're seeing as well is essentially just racism. The fact that COVID-19 testing initially all across the United States was not being located in those communities that were primarily Black or brown. So we saw this in Texas and all of the major cities in Texas. We saw it in Philadelphia, in New York, saw it in Tennessee and many other places, that when they started COVID-19 testing, that the testing was primarily taking place in wealthier and white neighborhoods as compared to African American neighborhoods. And if you're not getting tested, if you're not aware that you have COVID-19, then there's nothing that you can do about it to keep from spreading it to your family, to your loved ones and others. And that's something that's also contributed to the higher rates among Black Americans. And then last, I also published a study with several colleagues just 2 months ago, where we're looking at the effects of residential segregation in the US. Now we know that residential segregation is associated with many different types of diseases, from lead poisoning to higher breast cancer rates among African American women, to many other issues, even greater rates of HIV. One thing that I was curious about is to take a look at counties by demographics. So those counties that were primarily white, 88% or more white, we found had far fewer COVID-19 diagnoses as compared to those counties that were much more diverse, that were only about 60% or so white. And that's something, unfortunately, these data are from August. We just took a look at these data again last week, and we found that exactly the same pattern was taking place, that more diverse counties where there are more people of color have higher rates of COVID-19. And the first thing that you hear from people when they find out that COVID-19 is higher among African Americans is, well, what are you doing wrong to place you at greater risk? And that's something that we've heard quite a bit in our community for many different types of diseases. And the fact is that African Americans aren't doing anything wrong. When you take a look at various surveys, African Americans are more likely to wear masks as compared to whites. African Americans are also more likely to social distance as much as possible as compared to whites. But we still see higher rates of COVID-19 in Black communities. And there are many different reasons, so social factors that I was talking about, that are associated with it. But we are engaging in protective behaviors. And part of the reason why we're engaging in protective behaviors is because Black Americans are more likely to know someone who has died of COVID-19. A third of our community in some surveys have known someone who's died of COVID-19, as compared to only 1 in 10 white Americans. Now, one of the things that we also know is that we should have known that this was coming. We should have known that Black Americans were going to be at higher risk for COVID-19, because quite frankly, we went through this 10 years ago with H1N1. Back then with H1N1, it didn't spread as much as COVID-19, but CDC, while I was still with CDC, released data showing that Black Americans were more likely to be hospitalized with H1N1, including Latino Americans as well as American Indians, compared with whites. And very early on this pandemic for COVID-19, for the similar transmission of a disease that's a respiratory disease, people were saying, and scientists were saying, we have to do better. We can't have what happened with H1N1 happen again, where we disproportionately impact communities of color. But unfortunately, that's not the case. That's not what's happened. And there's a history of this pattern that's taking place in our country. I just want to show you, as I begin to end this presentation, some slides showing the prevalence of STDs in our country. This is the prevalence of chlamydia as well as gonorrhea in our country. And this is in counties that are primarily white. And you could see that these estimates are pretty much all over the US. When you take a look at these same estimates for Black counties, you see that there's particular in the southern United States, that we see higher rates of chlamydia as well as gonorrhea all cloistered together in specific counties in the US. This is something that also places us at greater risk because when you have a higher prevalence of individuals with these STDs around you, it places you at greater risk for getting this infectious disease. The same thing is happening with COVID-19. We have, unfortunately, the same thing happening with HIV as well. When you take a look at HIV and lifetime risk of HIV diagnoses by race, only about 1 in 104 white men are likely to get HIV in their lifetime. You compare that to 1 in 16 Black men. About 1 in 588 white women are more likely to get HIV within their lifetime. You compare that to 1 in 30 Black women. So we're seeing this in many other types of diseases where there are greater rates for African Americans. And unfortunately, COVID-19 is just the latest installment of that. So that brings us to where we are right now. You heard over the weekend that the US added 184,000 cases of COVID-19 in one day. So we're back on the upswing with an increase, exactly as Dr. Seal had mentioned. And we're looking at these data, we track these data on a dashboard that we have as part of one of our websites. And we just looked at what's been taking place over the last 2 weeks. So for instance, in the Northeast, there was a 104% increase in COVID-19 cases. When you take a look at Black counties, the increase was 115%. So it's greater than the average increase in the Northeast for those Black counties in the Northeast. The same thing is taking place in the Midwest. There's a 112% increase in COVID-19 cases among all counties in the Midwest. But when you take a look at Black counties, the increase is 131%. So we're increasing in cases at greater rates as compared to all other counties in the US. And this upswing, unfortunately, is going to land on the laps of African Americans. And it's going to be something that is going to be reflected in hospitalizations and unfortunately deaths. And two last comments that I want to leave you with is that unfortunately, racial inequality and mortality rates predate COVID-19. There was an amazing study that came out last month where they said that COVID-19 mortality among whites in the US have to increase by a factor of 6 to match the mortality rates among Blacks in any given year before we had COVID-19. So it just goes to show that rates of mortality are already so high among Black Americans compared to whites that even before COVID-19, for whites to get to the rates that are same for Black Americans, their mortality rates would have to increase by 6. So COVID-19, with or without it, is not necessarily the main thing that we need to be taking a look at. The main thing that we need to be taking a look at are these structural issues that are placing our communities at higher risk for COVID-19 and the racism that underlies it. And I'm just going to leave you with saying from HIV survivor who was talking about plagues and what plagues mean to us. And at the beginning of the COVID-19 plague, he wrote this, and this will change us as a society. It must. All plagues change society and culture, reversing some trends while accelerating others. The one thing we know about epidemics is that at some point they will end. The one thing we don't know is who we will be by then. And I agree that, yes, we do know that epidemics end. The one thing I disagree with, though, is that it doesn't necessarily change society and doesn't necessarily reverse some of the trends that we've been seeing. We've been seeing the same trend over and over again that places African Americans at greater risk for infectious diseases and other diseases time and time again. And it's about time that we stop this trend. And I'm looking forward to the discussion that we have about that today. Thank you.
Thank you, Greg. Thank you very much. That's powerful information. And I know we have a lot of questions in the chat, and we're going to go through our panel and leave all of the questions in the chat until then. But please put your questions in the chat. Thank you so much. And we're going to go move on to Dr. Ala Sanford who is the founder of the Black Doctors Consortium 19, and I met her on CNN. I was just so amazed by the work you were doing with Black churches around HIV testing. I said, this is a sister that I have got to find wherever she is. Found her in Jenkintown, Pennsylvania. But I was just so moved by your work, and I'm going to be quiet because I want to talk and hear about your work, the Doctors Consortium around testing, and Dr. Lisa Fitzpatrick is not with us, who was going to talk a lot about vaccines because her brother passed away. But please, as you're talking, Dr. Sanford, around testing, bring in the conversation around vaccines as well, because now we're hearing the vaccine is coming, and
Right.
you know how Black people feel about vaccines. We already decided that we are not taking the vaccine because you know we believe white people trying to kill us. So what are we going to do about that, Dr. Sanford? What are we going to do about that?
First, Dr. Steele, thank you so much, Seal, for the invitation. I really appreciated your overview, Mr. Millett. I mean, and part of the reason why I started this is because those statistics that you mentioned, I've been hearing for over 2 decades since I graduated from medical school. So if you saw the look on my face, which was like, it wasn't because what you were saying wasn't telling, it's just because every time I hear it, I get angina, like it drives me crazy. But we need you to give us the data so we can pinpoint what we need to do to make a difference and change it. So in essence, I was sheltering in place like everybody else. And in April 3rd to be exact, in Philadelphia, they posted that African Americans were dying at 52% in the city of Philadelphia. And I stopped. I was like, this is ridiculous. I called the mayor's office. I called my state senators. I called Congress people and said, what are we doing? Where are the resources? Where's the increased testing? And the paper that you put up that came out of Drexel showed that if you lived in a white zip code, you were 6 times more likely to have a testing location in walking distance than if you lived in a poor zip code. And I'm on staff at the hospital. And I said, hey, my friends are saying they came to get tested by you and you turned them away because they were on public transportation. They weren't in a car. And they're like, oh, we can't take walk-ups. Now, Philadelphia is largely a commuter city, of which most Black folks take the bus, the train, the subway, or whichever. So I just kept hearing these barriers. Then it was, you didn't have a state issued ID. Back then, it was you didn't travel to Europe. It was you weren't over 65. You didn't have enough comorbid conditions. There was a whole laundry list. Oh, and the biggest one, you didn't have a referral from your primary care doctor. So in essence, I talked to all my friends at different hospitals in the city and created a testing barrier-free program that was completely opposite of everything the hospitals were doing. So for the over 14,000 people we've tested thus far, I am the doctor of record for all 14,000. So that was that check. For people who didn't have insurance at the time, they billed me. LabCorp said, are you sure? I said, yes, you're gonna bill me and I'm gonna figure out how to pay for this later because people can't die for a test that costs $200. And after lots of going through the channels, they approved it and they billed me. Then the CARES Act was subsequently passed, but not before I had my $200,000 bills. Then the other issue was this comorbid condition thing, which for me, it was up to my discretion if you had symptoms or a true exposure. So I could make that determination. And we took walk-ups, we took drive-ups. If you rode your bike, it didn't matter. The other is that children couldn't get tested the same location as adults could get tested. So parents would come and they would come as a unit, a family unit, and then the kids couldn't get serviced or vice versa. As a pediatric surgeon, and many people on my staff also work in pediatrics, we could test a newborn up through 100. So there was nothing that we could not do. And in the beginning, I basically went through my phone and reached out to all my friends, sororities, fraternities, medical schools, college students, because everyone was virtual, and said, I need you. My mother rented a van. I talked to my pastor and said, we need to test in a parking lot. We need a central place. And he connected me with the churches initially that were in his phone. We showed up. The first day we drove house to house and people registered to get tested. And we spent too much time in the car. 2 days later, we did it in a church parking lot. And we tested folks. I got the testing kits and we tested 150 folks. By the third testing site, we were at Enon Tabernacle Baptist Church, which has a congregation of, I don't know, probably over 10,000 people. We tested 400 people that day and ran out of testing kits. And from then, it's just been, you know, we haven't stopped. And now we're going into month 9. The importance, and again, back to the data, we don't have a cure. So the only thing we can do is test and contact trace. That's how you stop the spread in our community. And I agree with you 100%. It doesn't have anything to do with our comorbid conditions. It has everything to do with access. And now that we have paused to analyze all the data that I was looking at all your publications like, damn, if I wasn't out testing, I could have published some of this stuff, you know, that we found. But we're working with University of Pennsylvania, which I have to tell you, in the beginning, the city wasn't interested, the state wasn't interested, Penn wasn't interested, Jefferson, none of the universities were interested. And once they realized we weren't going anywhere, that we were here to stay, and that everyone had decided we were the go-to place to get tested, whether you, by the way, were Black, white, Asian, Indian, Latinx, everybody knew that you could get a test from us 4 to 5 out of 7 days a week. So they started coming from far and wide to get tested from us. And in any case, what we found is, one, Black folks are younger. It's working class people. So I know in your data, when you talk in Georgia, it's 65 plus, and that's a high group, but our highest group is 55 to 64. And then after that is 35, because those are the folks that are working. Only 22% of our patients have comorbid conditions, okay? And 75% of them had health insurance. So this wasn't about, we didn't have insurance. It was that when we showed up to your health facility, you did not provide us access. That's what it was. So this has less to do. And then the criteria, you needed to have a comorbid condition, you needed to be 65, you needed to travel, and you needed a note from your doctor. We didn't meet any of those because we weren't older. The ones who were older were in nursing homes and they were getting tested, right? We had health insurance, but many of us couldn't get to a primary care doctor. Why? Because we were working, right? So the hours they were available to give you a prescription or to have a telehealth call, we were at work. And there were no nighttime and weekend hours like we needed, because we were the face front employees keeping the country running, right? We hadn't traveled anywhere. So we didn't meet the criteria. So we were the ones being diagnosed and dying, and every place had this stringent criteria and we couldn't even get in the door despite having health insurance. So that's in essence what we created. I'm proud of it. Now the city has given us grants. Everybody wants to give us grants. It's not enough, but it's been keeping us going. And that's where we are. Right now in the city, our positivity rates are back up to 20%. It's really, really hard. You know, 5% of my staff have had coronavirus. I have had coronavirus. I actually had H1N1 too when I was pregnant in 2009. And for some of my younger staff, they're like, oh my gosh. I said, just because you're a healthcare worker does not make you immune. You're still Black and Latinx, so you're still at a higher likelihood to develop it. And it wasn't even because, well, for me, it was for testing, but for others of my staff, it was because their husband was a police officer. It was because their wife was a bartender. It was because they took public transportation to work. It was because someone in their house worked in a restaurant. Someone worked in a nursing home. So even though you're a healthcare worker and you're wearing your PPE every day, other people in your household are being exposed. And then you're coming home and then it's spreading. So it's hard right now for us. I got a lot of people out sick. The rates are going up. At my church, Salem Baptist Church, we tested and gave flu shots to over 430 people last Thursday. 430 people. And we were out there all night. I expect it's going to be that way all week. But we're ready. We're ready. Okay, vaccines. Let me check my time. That was 10 minutes. Okay, vaccines. I am on the CDC Philadelphia Department of Public Health Vaccine Advisory Committee. I've been on since September. And I realized, one, I appreciated the invitation, but I also realized they were strategic in inviting me, knowing that I'm a trusted leader in the community and in some places across the nation. And they wanted to make sure that I was on board when this vaccine came out. Now, so right now we're dealing with two. There's the Pfizer and there's the Moderna. The Pfizer vaccine is a 2-dose. You get 1 dose, you get a second dose 3 weeks or 21 days later. And then you're supposed to monitor for 2 months. It has to be stored at -70 degrees. And that's that one. The Moderna is a 1 dose. And both of them are showing right now greater than Moderna, you're saying is 2 doses? Okay, well, I have to double check that, but I'll take your word for it. But both are touting greater than 90% immune response. Now, here's the thing about that. They're only giving you preliminary data. The CDC Advisory Committee recommends 160 to 200 with greater than equal to 50% efficacy. They're not there yet. They've done about half of that, 100. So I suspect that 90% that they're touting, 94%, will drop a little bit, but it'll probably still be greater than equal to 50%. My issue with the vaccine, and I've said this publicly, so I don't think I'll be in trouble about it, is there are 3 phases. The first phase, phase 1, are high-risk individuals. These are nursing home residents, people in congregate settings, and frontline workers and healthcare workers. That's number 1. Phase 2 are moderate risk, and phase 3 is everybody. Now, the phase 1 and the phase 3 are pretty clear. Healthcare worker, nursing home resident. Phase 3 is everybody. It's that phase 2 that I'm very concerned about, because that's up to someone's subjective interpretation of what makes you moderate risk. And again, your comorbid conditions, which I've already told you, Black folks, primarily the working class folks, may not have that many comorbid conditions. So I'm very concerned about that phase 2. That's my one concern. Actually, I have 3 concerns. That's one. The second concern is, and I hope the phase 3 data will show us, 85% of the Black folks that we've tested for antibodies, now COVID antibodies, meaning they've had the disease, and we started measuring antibodies at 3 months, 6 months, and now we're on our 9-month because we've been testing folks since April. 85% of the people we've tested have COVID antibodies. And I want someone to explain to all these Black folks with antibodies, myself included, that this vaccine is more efficacious than the antibodies I have in my body. That's my number 2, that I'm waiting for the phase 3, and maybe it's going to be borne out. Maybe it'll tell me my antibodies plus the vaccine will give me a more potent response. But you need to be able to answer that question for me. My third concern about it is the long-term effects. And the reason why vaccines usually take 4 years to go on the market is because, you have your different trials, you do your safety and efficacy, you do adults, you do kids, and then you monitor them for 2 years to see, do they have neurologic difficulties? Are there any deaths that could be attributed? What types of long-term effects came from getting the vaccine? With these 2, even 95% efficacious, what we don't have is time. And for me, that's tough for me as a wife, as a mother of a 12-year-old and 10-year-old twins, not knowing that is tough for me. Now, if I were 75, it might be a different story. You see what I mean? And so that's my own personal challenge with it. And that's why that antibody data, and we know they don't last forever, but neither does the vaccine. Vaccine is supposed to give you immunity for a year. Right now at 6 months, folks still have antibodies, right? And maybe the antibodies will go away at 9 months, but if someone tested positive today and they have antibodies, in March, they might still have antibodies. So should they get it? That's a question I really need to hear answered before I can be an advocate for taking the vaccine. So those are my 3 concerns. The logistics part, everybody's talking about it's -70, is this, that's not going to be as big an issue as we think. With Pfizer in Philadelphia, what's happening is these enormous, freezers are coming. We have different locations throughout the city where they'll be housed at the different hospitals. My staff, for example, as frontline workers, will have access to the vaccine. We'll have individual coolers. Once you defrost it, if you will, or let it get down, you'll have about 4 hours to administer it. So that means you have to have people pre-registered, so you're not wasting the vaccine. I don't think that's going to be a problem. If people say they're coming to get it, they've pre-registered, you've explained it, they're going to come take it. So everybody talking about -70, these freezers, the containers, that's less of an issue. The big issue is the science. The logistics can be worked out. So what I have to say is I'm just waiting for information. People keep trying to get me to say I'm gonna take it, and I keep continuing to say I need more data. And as someone who's had COVID, as a Black American woman, these are questions I need to know for myself. And it may be that some of us should not take it, but some of us should. And if you've had multiple family members die, multiple people close to you be exposed, be very sick, and still living with the residual effects, for you, the risk might be worth the benefit. And so I'm not discounting it at all. I'm just simply saying, I'm just trying to put as much information out there as I can so people can make the best decision for themselves. And my decision may not be your decision, Dr. Smith. It might be a different choice, right? So that's all. All right. That's enough. I'm done.
Unfortunately, we're going to have to, go to Reverend Dr. Thompson, but there's so much, thank you so much. But I do want to I'm going to take a facilitator's privilege and ask one question, because I know there's some people that want to know this question. When you say that, African-Americans, we live in a household where we go to work, we're getting it because someone's going to work, they're the bus driver, or they're working in the cafeteria, or they're the school teacher, or whatever. So how do we prevent getting it when we're living with folks who are, do we wear a mask in the house? What can we do when we are in this culture?
Right. So one, we have to be vigilant about it. We have to be, there was a time when HIV came out that everybody was kind of like, I don't know who you've been with, kind of thing. And not to have, for it to have a negative stigma, but just being vigilant. For example, well, gosh, I can't give you an example without being personal. If somebody comes home, it's only how many hundreds of people on this call. For example, if your loved one comes home and they're sniffling, it's not a cold. It's COVID until proven otherwise. It's COVID, period. Okay. And so not everybody has a guest room. Not everybody has a basement, but you might have a bedroom. And I think as soon as somebody has a hint of a sniffle, a cough, like if I'm out and I see somebody cough, I'm like, what? You little, kind of thing. I mean, I've even said your mask is kind of low. You might want to lift that up to people. I have no problem saying that at all in public. And the same thing with our family members. And you put that person in a room and say, listen, we're going to get you a test. But until then, I'm going to bring your food to the door. and you keep them in there. If you have 2 bathrooms, if you only got one, if you have 2 bathrooms, it's easier. But that person you're waiting for their status, they're the only one that uses that bathroom. Nobody else uses it. If you don't have that, then you got to wipe everything down with bleach. And we know how to wipe stuff down with bleach. We know how, you know, wiping the handles down, the faucet, everything. And for example, for myself, when I came home sick from testing one day, I wasn't sure. I got tested and I'm blessed. I had a guest room with a bathroom. I stayed in there for 4 days. I stayed in. I didn't come out. My kids were sliding me notes under the door. They were trying to come in and I kept closing the door. Mommy's sick. Mommy's sick. Are you okay? Mommy's sick. You can FaceTime me, you know? And they would leave me chicken soup on a TV tray outside the door. I did not leave that room. And thank God my husband and none of my children were infected and none of them have antibodies. So it can be done. So answer to your question, it is be vigilant. Know that we, even as a healthcare worker, even as somebody making 6 or 7 figures, even as a doctor, you have all these titles. At the end of the day, we're Black, blessed to be Black, and we are gonna be more prone to getting it. It's not about how much money you make. It's not genetic. It's just culturally who you associate with, you know, that we are more prone. So we have to be vigilant and protect ourselves. So in your household, that person, you cater to them, do as much social interaction you can without touching them, right? Until you know your status. In our city, we do have places to quarantine. They have some hotels set aside. I want to say not the convention center, but some dormitories. So the city of Philadelphia does have a location for these homes where there's a grandma and a baby and everybody in between, where you can safely go and stay for 14 days. Not every city has that, but Philadelphia does have that when you need to isolate. So.
All right. Well, thank you. I'm gonna hold my peace, and we're gonna go to Reverend Dr. Jacqueline Thompson, the senior pastor of Allen up there in Oakland, California, and hopefully I can hold my peace so everybody can get their questions. All 400 of you will get your questions through at the end of the session. Reverend Thompson, come on in. Come on in. Oh,
thank you so much. I'm so blessed and honored to be here with you, Dr. Seal, and with this distinguished panel that I've been blessed thus far by the information. Thank you, Dr. Stanford, for freeing me, because I thought I was the only one looking at people crazy for not having their mask on, or when they cough. We are pre-recording our services. So if somebody comes in after we've screened them and they cough, we all look and say, oh, hold on now, wait a minute. Brother Millett, thank you for all your information as well. I am on this call because our church has been blessed in the last, I won't say the last, about 4-month period to test over 20,000 people. And so I know, Dr. Seal, you wanted me to talk about how we were able to do that. And so I know I'm talking to faith-based folks and church folks, so I'll just be very transparent and very honest as to how I came to this. Right in March, before the shutdown, I think we shut down in the Bay Area, in Oakland and San Francisco, right around March 17th. Within that next 2 weeks, we lost the oldest gentleman in our church, a patriarch. He had not gone into the hospital for COVID. He went to the hospital for a surgery. He was 94, planning his 95th birthday party. He's a former professor at San Francisco State, had just taught for us for Black History Month. He sent me a message on Facebook, because even at 94, he had mastered Facebook. And he said, Pastor, I had a shoulder surgery, and so I'm not going to be at church. I'm going to watch you on Facebook. I said, no worries. It's fine. Take your time, recover. Within a week's time, he had the surgery, went into a skilled nursing facility, came out of the skilled nursing facility, came home, developed a cough, went to the hospital, never came out. It was the last time that we saw him. He went to the hospital alone. He passed alone, went to the funeral home alone, was buried alone. And we have yet to be able to celebrate his life. So Mr. Millett, when you were talking about those persons who were likely to know someone who had passed from COVID, I was that person as a pastor. And it broke my heart, because I had to watch his wife They had been married over 70 years. Watch him through the gate be lowered into the ground. Because if you had passed from COVID, the funeral homes would not even allow you into the burial site. And so I kept saying, as we do, as the Black church, which has historically been on the forefront of all of these fights. And if I think you said you were at Salem, if Dr. Mitchell, Pastor Mitchell's still there, please greet him for me.
Yes.
I said, we have to do something. Allen Temple Baptist Church is located in a predominantly African-American Latino community. We are an impoverished community, everything that comes with that, unsheltered people, blight, all of that. And so I did what pastors do. We prayed.
Mm-hmm.
Because if he could contract the virus unsuspecting, because the national leader, the occupant of the White House, was still going around saying it's going to magically go away, it's not going to happen. I said, how many more unsuspecting people are going to be adversely impacted? With the difference being that dominant culture folk, they contract it and they are treated and they live. We catch it and we die. And so it became for me an issue of awareness, access, and advocacy. I went on social media and said, we need testing sites in our community, because everything you raised, Dr. Stanford, was true for us. Even if we had symptoms, we would show up at the doctor, and if it wasn't a fever, or if it wasn't something that was on the list, they would turn us away. So we had people who would go and who would have symptoms, who later were tested positive, who originally showed up at the hospital and was sent back home. And so after you bury the patriarch of your church, after you have to watch a family take their child off life support, off a ventilator, and you lose both the mother and the baby, then you recognize that if you don't fight it actively, it has the potential to devastate your community. So we were pre-recording every week. I would stand in the pulpit and say, we need to be tested. I called the mayor. I called our congressperson. I called county people. I called people who I knew had influence and who knew people, and said, we need access to testing. And so honestly, early in the disease, the county, after, they realized, because I just feel sometimes you got to shame folk into doing right. Y'all forgive me. You just got to shame them. You got to put them on blast. And so when the county executives called back, they said, Pastor Jackie, because that's what they call me, we have to be honest, we don't have tests. So that's enough. Very early in the disease, they did not have tests to be able to put out. The hospitals had a shortage for testing. And so, Bishop, hopefully you will appreciate this. People of faith, you'll have to appreciate this. I prayed and I said, Lord, there has to be somebody. There has to be someone who has access to this. And literally, and I'm going to try not to be emotional, I was watching CNN, and there was a nonprofit agency by the name of CORE that was sponsored by Sean Penn and some other folks who had set up a drive-through testing site in Los Angeles. And I looked at the television and I said, Lord, that's who we need. That's who we need. And literally 2 weeks later, I got a phone call from a representative at the county who said, can we connect you with this nonprofit agency? We have no funding to do it, but if you all can make it work, we'll see what we can do. They flew down to our site and set up a drive-through testing facility just like the one that I saw when I watched CNN. So forgive me if you think I'm being spooky, but I just have a little bit of faith. Believe faith is real. Believe the Holy Spirit is real. Believe God answers prayers, that God will leverage the resources that we have available in the community to make sure that his people are healed. And so for me, it took us recognizing and really challenging our theology that as Black churches, we cannot just be in the business of thinking that God wants us to save souls, because why would you serve a God that wants to save your soul but will allow your body to be damaged? And so we set up drive-through testing. We've been able to test about 20,000 people. We were seeing up to 300 persons a day. And Bishop, it was amazing because, we weren't able to gather and people were mourning, but now I could call the usher board and say, all right, if you want to shepherd some folk through, I need you to stand under this tent. tell them don't roll a window down, hold your ID up, right? So all of our ministries were able to be involved. And the amazing thing was, it wasn't just young people. I had older people. I have seniors who told me I was discriminating. Don't shut us out just because we're in the population. We want to come, we can hold a pad. So it really has been an amazing transformative experience. Now, I have to be honest, when we initially started testing, I was very worried because the people in our local area were not utilizing the access. It was people driving from wealthy areas, San Jose, San Francisco. And so a lot of the faces, we would sit and we would look and know everybody who drove through did not look like us. And so it meant that as a church, we had to change kind of our advocacy strategy. And so I was able to call in our evangelism team, and we went old school, Dr. Seal. We took them flyers and we walked up to Pookie and we walked up to people on the corner and we was like, look, boo, it's a real thing, right? Come on down. And like Dr. Stanford lifted up, originally we were not a walk-up site, even though most of the people in our neighborhood needed that. And so now we are both able to offer walk-up as well as drive-through. But God has been gracious and God has been kind to us. But literally, I need for churches and church leaders, the biggest challenge we faced was awareness, that for churches who want to join the fight, they weren't even aware of who to call and who to have relationship with. And so that's why we don't critique churches, who understand what it means to have influence and be political. You need to know who your mayor is. You need to know who your city council person is. You need to have relationship with your congressperson. This is why voting matters. All of it is connected. Because when we get in situations like this, we need to be able to pick up the phone and have someone who is for us on the other side answer, and be able to go into the room and advocate for us. So between the emails, between the public shaming on social media, between asking people in our services every week, we need to be tested, then we had to encourage our people, it's safe to come. Because there is a stigma, first of all, a mistrust of institutions in general, particularly the Black church. There was also, Dr. Seal, you remember, because when I was at Shiloh in DC, we were an alternative testing site for HIV/AIDS. And people were able to come to the church and be tested, but we had a challenge getting people to come and get their result because of the stigma attached to the result at an actual church. So there were lots of things that we had to do, but eventually the color started getting tanner and tanner through the drive-through sites. And we were open 6 days a week. We had alternative hours from 1 in the afternoon till 7 p.m. because many of the people were still working. Many of our people never sheltered in place. They couldn't afford to shelter in place. If they sheltered in place, they would be homeless. And so we had to offer evening hours in order to do that. Second thing was access, making sure that, when there are dollars available, how can faith communities partner and collaborate and know who to connect with to have access to those dollars? We have the access to the people, we have the willing workers, but often churches don't have those resources. And so the pandemic has forced us to put all of that competitive foolishness aside. How many people on your roll? How big is your budget? None of that matters when we're all trying to serve people. If you have a parking lot and you have people who are willing, to be trained, come on, let's find a central location and let's get this work done. And then I think the last thing, as I said, would be advocacy, that we have to be willing to stand on the front line and take the hits. I'm challenged because now that the vaccine is a possibility, I think the one thing we have not hit is the reality of structural racism. And in the way that these kinds of things have been used, we are not only disproportionately impacted, but I am concerned that when it's time for a vaccine, it will be used now to keep us out of things that we've normally had access to. It's been said now that in order to go to a concert, that there are agencies that are going to require you to be vaccinated or show a negative COVID test. And so how is that going to play out? Will it begin to affect our travel? Will it begin to affect places where we can go and where we can't go? And so it's a lot for us to contend with, but I'm excited that, God has allowed us to be on the forefront of this fight. I'm very, very grateful to the wonderful people of Allen Temple Baptist Church who have not pressured us to return. They are perfectly okay with virtual. Part of me feel like they're too comfortable with virtual. They like taking communion at home in their kitchen, Bishop, with their real wine, not the grape juice we they get their real red wine. But I am grateful for that. And so we are continuing to test. With the winter months, you know, outside testing is going to be a challenge. We'll have to figure out how to shift to an indoor model and still keep everybody safe. But that's kind of our story and what we've been doing. And so we are grateful for this work and grateful to be here with all of you to share our story and our testimony.
Wow, 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 wow. I'm going to hold my peace because I know folks want to jump in and ask questions. And Bishop is raising his hand, something he does not do. He has something to say. Bishop Horace Smith, you go ahead.
Well, I'm not going to take a long time, but I want to start with this, to this entire panel and to this entire audience. What you've heard from every speaker is really the linchpin. As Black people, we've got to, and Dr. Thompson, you ended it with the right thing. We must get over our cultural competitiveness. We must know something, that all of us together have the same alternative, the same objectives, and we had better learn. I've learned in COVID, we must work together. There's no one answer to everybody, but we need to hear each other, because the other folk, unfortunately, this is the negative part, they're not going to hear us, not really. They can't. They don't have the experience. I think we have to also understand with this vaccine business, and Dr. Stanford, your case is amazing. Dr. Thompson, Brother Millett, you're wonderful in these statistics. This is a multifactorial answer to vaccines. I started with Northwestern 4 months ago when they called me and said, we are in phase 3. We've been in phase 3 for a week. We have 5,000 volunteers and there's 0.5% African American. My first issue was, and because I'm a scientist, you cannot develop a vaccine for a pandemic that affects us the most, but we don't participate in the trial. So we had to fight uphill to get Black folk to take the trial, to sign for the trial, which I thought was critical, because we all know as scientists, you don't want a medicine that has not been tried in the people who are most affected. You've got to be on those front lines, and you can't wait for somebody else to be tested for you to be sure, because death don't care about how long you're going to wait to get statistics. Some of these things we've got to change, even though it is somewhat anti-thought. We don't have time to wait to see the long-term outcome of these vaccines. We don't. I said to my church 6 months ago, you're gonna get COVID or the vaccine. Those are your only two reasonable choices. You are not gonna shelter in place for 2 years. It is not tenable. So we've got to make sure we are also in charge of the vaccine and how it was developed. Now we're through that, but you raise a point, Dr. Stanford, again. I told them 2 months ago, who decides distribution? I don't trust y'all. Who decides who's on the front line? Because again, we've got to, as a community, do what you guys have all done. We got to speak loud and not be quiet, but we can't be tunnel vision about our experience. My one caution to our experience is this. I tell my church, your experience with God is your experience, but it does not define God. So be careful when you say we should all do this because I did that. Hold it. That may not be true, because again, I think that what they're not doing also in this vaccine business, how do you give a vaccine if you don't know the antibody status of a patient? If you've got antibodies already and I give you the vaccine, I get the wrong indication from the vaccine. So a part of what we should have been talking about is, should they not, I know it's another step, should they not test people? Because again, if I've got IgG antibodies against COVID and you give me the vaccine cannot work because my immune system is already guarded against the antigen you're given. There's some questions we don't know about, and it may be that some of these things can't be answered. So I say to Black people, don't go on this, Unitarian, what we gonna all do, hold it. You've got to think and pray about each scenario, because if you don't, you're going to further endanger Black people by telling them they're using you as a guinea pig. Look, these white folk ain't signing up for this vaccine to be a guinea pig. They are not doing that. They know that COVID is a real deal. And if we don't get some protection from it, we're gonna lose another 100,000 people in the next month without a leader nationally who helps all of us have a national multifactorial way to deal with COVID. And so I just want to applaud all you guys. You guys are amazing. We need these voices. I said, all these Black leaders, stop speaking to your fears. That's the other thing. Stop speaking your fears. Your fears won't protect you from the reality. Truth does not care how you feel. Truth is truth no matter what. So we've got to make sure we got the right understanding and then help our people and shelter them along. And I'm just glad to be a part of what you guys are doing. I'm gonna stop right there.
Let me see if you can hold your peace, Bishop. I doubt it. I doubt it.
I was gonna say amen.
Greg, I want to circle back to you. If you have the question, I'm gonna give it back to I don't know how we do the chat thing. I forgot about that. But Greg and Tanya, you all figure out the chat because that's just too much for me, you know?
Let them do it.
Yeah, let them do it. Go ahead, Greg and Tanya. Give it over.
Sure. Now, there's several really good questions in the chat. So I'm going to go ahead and read them, and then we can have, each of you, myself included, comment on them. So one of the questions was, do you still have to wear a mask if you take a vaccine? So that was one question. Another question that we got are, what are the proportion of African Americans, or what are the number of African Americans in the vaccine trials? And then a third question that we got are what are the safety data that are associated with any of these trials? Do we have any more information about the safety data? And it's wonderful because Bishop Smith actually got to another question, a last question that I saw in there, which is, do you give vaccines to people who already have antibodies? And what does that mean? So we got to that, but most of the stuff in the chat are people just sending blessings and saying thank you for all of this information. So those are 4 questions on the table right now, and please feel free to respond.
So I know most about the Pfizer one because that's the one we've been talking about on the vaccine advisory committee. So the first question, and I might do these out of order, if you get the vaccine, do you still need to wear a mask? Yes, because even with 90% immune response or efficacy, and if it drops to 80%, that means 20% of people, and you don't know where you're going to be, did not develop an immune response. So the vaccine, it's not like it's 100% of people have an immune response. So yes, you still need to wear your mask. What was the other question? I
Sure.
heard.
What's the numbers of proportion of Black
yes.
Americans?
So Pfizer is 30%, which I was surprised. Pfizer was 30%. That it is when you think about the fact that we represent 13% of the US population. So to have 30% people of color, I thought that was a good, percentage. And Bishop Smith, we could talk offline about how relevant the color is with this particular disease, because it's not like sickle cell or Tay-Sachs, but that's for another conversation. And then the other question, which is, I think the one we're both talking about, is the antibodies. And especially now that I have them, that I really want to know. I want someone to quantify my IgG right now and tell me that my IgG is 70%. Right. And then I want to look at the phase 3 data and see after the second dose, when you measure the IgG levels, what is it? Is it 50%? Is it 60%? Okay. And if it's similar, then I would like to keep my antibodies and not. But I think what we both said is one size doesn't fit all, and you can't generalize us. And as I gave that example, someone who's been affected and older and can't afford to not work, and they're going to be constantly out there, you probably, the risk is worth the benefit for you to get that, right? And I'm really hoping the data, when I started on this committee, they were like, well, Black people don't trust the healthcare system, so they shouldn't be prioritized first, and we shouldn't allocate it to them because they probably won't take it. I was like, whoa.
No.
That was that. And these are all educated, doctors.
They're all educated.
I was like,
smart.
listen, let's not generalize and put every Black person in that category to say that we unanimously don't or have a mistrust for a healthcare system that's been untrustworthy to us. So let's get that right. Well, Black people don't trust the healthcare system. No, the healthcare system has been untrustworthy to African Americans since its inception. There's a difference.
True.
So I'll stop because I could keep talking. Let me mute.
Wonderful. So 2 quick follow-up questions, but one quick thing too is at the Moderna trial, it's about 7% Black American. And that was the number of participants, 7%,
Yeah.
as of mid-September.
Yeah.
So that's what we do know. A couple of questions others have
And
been
that's
coming
pretty
in.
awful. And that's awful.
Absolutely, absolutely. So some questions about, are children able to take these vaccines is one question.
No.
Another question is, if everyone in your family is diagnosed with COVID-19, do you still have to wear a mask at home? And then a third question that came up as well was, are there any herbal treatments to address or to deal with COVID-19? So I'll leave you with those 3 questions for now.
Oh, wow. Can I just wait on this?
Yeah.
Dr. Stanford, the issue of antibodies is also for you this. If you've got antibodies and you get a vaccine,
Yes.
the vaccine of itself may be efficacious, but in your case, it won't, because your immune system will not recognize the foreign matter.
That is correct. That is correct.
So
Yeah.
that's why I think that there's some questions that cannot be answered for individuals because they are so different.
Yes.
Because overall, we don't test all kids for measles because we know that 99% of the kids don't have the measles.
That's
So
correct.
we vaccinate them. But I've got patients who have had vaccines, who have measured protective antibodies, and 3 years later, when they're going to work in a healthcare facility, you measure them and they're gone. So there's some things we cannot answer. We really cannot answer those questions. We must deal with, however, the broader issue, again, of why. I said this 5 months ago. This country had the capability and the wherewithal 5 months ago to offer free testing frequently for everybody. And we could have done that, but we have no national study. The other point there is that 20% of people are going to be asymptomatic without question. So you cannot use even a minor symptom like a cough in your home. You have to do like we did, Pernessa, with HIV. You must assume that everybody is positive. If you don't, you're going to still have these hot spots because people have not been tested. We've got to get frequent, free testing for everybody, even now. Otherwise, we're not going to be able to isolate people who are positive, know who they are. They can get the proper quarantine, or we're going to be in shelter for another 6 months. So I think that some of these things we have to continue to do, even with the vaccine. The vaccine has been touted by a certain person in the White House as an answer to everything, but it is not. And I'm going to tell you right now, with the best vaccines, it's going to be at least now next year before you can safely not wear a mask. If we do it before that, you're going to find out we have not tested enough people. You've got to do it, and you got to do it frequently. It's like the young women say to me, I'm gonna sleep with so-and-so, he showed me his HIV test. I said, yeah, that was 3 days ago. And you don't know who he's been with since then. So be careful on the limits even of those things. We've got to use wisdom. And let me back up and shut up because
how would you answer the everybody in my house has had COVID, do I need to wear a mask? I'm just curious. I know how I would, but I'm curious how you would.
I think households that have, I quarantined the last 3 months pretty much with my children and my grandchildren. There's 15 of us who have almost selectively stayed only with each other.
Yes.
So is that 100%? No, but in your home, it is not practical for you guys to be a family and not have to wear a mask every moment. I don't think that's tenable. Yeah. I think that you have to do what you said, get tested for people right away if you can, because in your home, you have to operate that way. It's hard to, you just can't, because you're gonna go out, you may go out tomorrow and do some work, and come back in? How do we know you didn't
I
get
know.
infected then?
I
You see what I'm
know.
saying?
Yeah.
So there are some practical limits that are
Yeah.
not going to be 100%.
Right.
That's where the wisdom comes in. And I think we have to be selective and thoughtful about it and use trusted voices, or we're going to do something with good intention, but folk are going to be hurt. This notion about that Black folk are a monolithic community has hurt us for a long time. I tell these people all the time, look, we are individual churches, groups. We do have some common thinking, but at least get enough of us in a room together and listen to us, and you'll come up with the right strategies. What they want to do is very paternalistic. They want to make a decision and tell us. I tell all these white folk, and my friends know this. I tell them, don't tell me nothing. I train your people. No, you talk to me, because then we can have a conversation, because you telling me is not going to convince me unless I can in my mind say, yeah, that's right. Because they have minimized us, even the best of us, as if we don't count. And that is utter stupidity.
Dr. Sanford, let me jump in. How would you answer that question?
Yeah, for everybody in the household, yes. I think what's tricky is everybody tests positive, but 2 people weren't sick at all, right? Meaning they were subclinical or were asymptomatic. And usually that can correlate with you not have developed antibodies. Not always, but it can. So this is what I would say to you, particularly as someone was talking about the testing. That damn test is free. It's free. So please, when you see these billboards that say, come get your antibody test for $150, don't do it. It's free. And until that CARES Act money runs out, that test is free. So when people come to me, I tell them, I'm trying to test everybody Black in the city of Philadelphia, New Jersey, Delaware, and Southeastern Pennsylvania. Now, of course, white folks, Indian folks, Asian folks, everybody else then also figured that out, and they're coming too. But so that's why with the antibody test, and if you can reimburse through HRSA, which I am, those tests don't cost them anything. And so for the people who have insurance, we collect it, but I don't charge them the copay.
Good.
And for the people who, that's how I can say no cost and it's free.
Good.
So I don't try. If the test is $100, your insurance covers $50. Thank you very much. You will not be getting a bill from me. And for everybody else that has no insurance, we do it through HRSA. So don't let somebody tell you you can't get a test because you don't have health insurance. Keep pushing. Keep pushing. You can email me. You could email Reverend Dr. Thompson. We will figure out in your area where you can get a test for free. That should not be an impediment. It doesn't cost the hospital a damn cent. They just don't like the fact that the reimbursements are low and it costs more to pay somebody to do the test than they get back in a reimbursement. That's why they're not telling you. It don't cost them nothing.
Thank you.
And you can lobby your local officials to advocate for how those dollars are advocated. That's the other thing. You can talk to your county health officials. You can talk to your city, your state officials, and they can reallocate resources to communities that do not have dominant access. They absolutely can do it. And so it becomes the responsibility of those who have the microphone, those who have platforms, all of us coming together, use who you know. They can change it, I promise you. Within 7 days, they can say we were testing here, but now we're going to redirect and test there. But it is really the old adage that we heard growing up, a closed mouth does not get fed or tested in this case.
There you go. Now, I have a quick comment and also one question. Now, the quick comment, because several people brought up HIV as well as HIV testing and what's going on in several churches. There was a study that was just published 2 weeks ago from South Side of Chicago, where they found that they were actually diagnosing more people with HIV during COVID-19. And that was because there were people who are African-American who were coming in saying that they're feeling sick. They thought that they had COVID-19. They tested them for COVID-19. They were negative. But when they tested them for HIV, they were actually HIV positive.
Yes.
And some of them were just seroconverting. Others were just had their first opportunistic infections. And these are people who previously had not been tested before. So their recommendation is that we should be doing testing for HIV as well as COVID-19 within our particular community. So that's one quick comment. The other question, though, is about the politicization of COVID-19 and the politicization that has really brought many Americans away from COVID-19 testing. So there was a poll that came out last month that showed that 6 in 10 Americans would take a COVID-19 test if their doctor said that they should take the test, but only 2 in 10 would take it if President Trump suggested that they should take that test. So that begs a question. So that begs a question. Now that we have a President Biden, as well as a Vice President Kamala Harris, do we think that the numbers of people who actually get tested or enroll in a vaccine trial might change in the Black community because it's not a President Trump who's saying that we should be a part of the testing, but now you have a different administration?
He didn't want you tested anyway. You know, healthcare is a trust factor. All these, Dr. Stanford have to tell you this. You can live next to the university. You're not going there if you don't trust it.
No.
Healthcare is a trust issue. The voice has to be trusted. If it's not, there's going to be a long road to overcome mistrust. Black people sometimes are not trustful, but they have a reason. It's called self-preservation.
Yes.
The history in our country, unfortunately, and this is the biggest issue that we have not talked about, and we can't keep doing it, is that this is, in the election showed it, this is a racialized country. We have never, ever officially repentant nor acknowledged the issue of this country, and it's going to keep dogging us with every major issue, whether it's COVID or economics or whatever, because we have not dealt with the truth that we have to, as a nation, come to a conclusion that what has been done to Black people and others, Native Americans, is reprehensible. We repent of it. And here's how we begin to chip away at it. Until we do that, the pessimistic view is that we're going to make little small strides and fall right back with the next problem, because folk have not been honest and truthful about the history of this country, and getting the vaccine ain't gonna change that.
Right. And I would dare say that we have to adopt the model that we have always adopted, and that is we have saved ourselves. The voices that we have listened to have been local voices. So I'm not sure that with the change of administration and all of the intensity that was shown in the turnout to vote had anything to do with people having any more confidence in this particular new administration than the one that we currently have. I think they just wanted the one that we currently have out. And so what I have found is that when we were trying to get people, particularly local people, to test, it was not the governor, it was not the mayor. I had their pastor drive through the testing site and, you know, take a picture, film themselves, put it on Instagram. I had local youth leaders plan testing parties, because we trust people that we see every day. Right. Not necessarily, you know, someone who is in the White House or in any form of government. So it's going to take all of us, again, from the top level all the way down to influence wherever we've been placed to influence, to make sure we attack the disease. It is my hope that, you know, we have a new administration that trusts science, that listens to science, that listens to doctors, that is not going around telling people it's going to disappear or just go, you know, puff the magic dragon. It's not going to be here anymore. That they will actually put out factual information, and that will help cultivate more trust than we've had until now. But I think it's going to be local. You know, there are people who simply being on this particular session because they know Bishop Smith, because they know Dr. Stanford, because they know you, Brother Greg, because they know the work and the history and the labor of a Dr. Pernessa Steele, they will embrace this information, use it, and take it back, regardless of who's on Black Lives Matter Avenue in the White House.
So I know that I want to stay on this forever. But I want to close with the final question, Greg, because we are running out of time. And we got to be back for those who are coming back to our cooking demonstrations at 6 o'clock.
Right.
But you know, I want to ask each of you, from Dr. Thompson to Dr. Sanford to Greg and then Bishop. We are coming into now the Thanksgiving holiday and Christmas holidays. And you know, we the family, we love Thanksgiving and we love Christmas. We gather, you know, it could be 20 degrees outside and my family will start barbecuing a pig or something outside. They don't care how cold it is, you know, and some of us, like I am, we're struggling. You know, it's like, I got to go to our P's house. We always have a good time in our P's house. How should we respond? We have some people saying cancel Thanksgiving, cancel Christmas. Well, you know, some of us are not going to cancel Thanksgiving or Christmas. Some of us are. But as pastors and doctors, how do you tell the past what should be our voice to the community and the family as we move into this our high and lifted up holy days, Thanksgiving and Christmas. Dr. Thompson, I'm gonna start with you. Yes, you got the mic. Tell us, and this will be.
I'm like, oh no, Bishop had unmuted. I was waiting for the bishop. We're gonna follow the science. And since he's combined, he's both faith and science.
We'll let him have the last word.
We're gonna be an echo. I would say, I think I would echo once again what has already been said repeatedly by everyone who has spoken. That is, Black people are not a monolith. I cannot speak to what Aunt P needs to do or to what any, you know, Dr. Stanford or Greg needs to do. I can only speak to my particular context. I personally have a mother who is 91 years old, who is living victoriously with dementia. And so as such, we have taken extra precautions. We are still going to have holidays, but it won't include all of the external people that it would usually include. And the main reason is because we recognize that we are the greatest risk to her. When you all were talking about the mask question, I do wear a mask because I recognize that I'm still living, moving, having my being, having to run the institution and coming back home to someone whom we know will not survive if they are exposed. And I don't think that's a risk I should take. And so unfortunately, I'm not sure if it is helpful, but everyone needs to assess the risk based on their own environment and their own context. So we're gonna have food regardless, even if I'm by myself. It's gonna be some cornbread dressed with sausage in it. Yes, it is, forgive me. It's gonna be some greens and some sweet potatoes and some, you know, and we may have to have a Zoom fellowship and we can watch one another eat it. But we're scaling back, because at the end of the day, I want everybody to still be here for that time when we are able to gather. And I don't want anything we do now to adversely impact what we might be able to do moving forward.
Amen. Dr. Sanford?
Don't do it. You know, I hope I have another 40, 50 years on this earth. And, you know, if it means I have to sacrifice this entire year to get to see that with my family, then that's what I'm going to do. My Thanksgiving will be with my husband and my 3 children. I have 3 bonus children that are in college. 2 of them are in college, 1 is grown. They will not be coming in this house because they have roommates. I gave everybody the option to test on Sunday. Oh, I had a plan. I said, I'm gonna test everybody on Sunday and I need you guys to quarantine till Thursday. Don't leave the house. I was even inviting my husband's ex-wife and my ex-husband, everybody, 10 of us, because I realized that with the different households, in order to make them part of my bubble, we all had to quarantine and we all had to test. So I was going to test on Sunday, get a negative result Tuesday, and you were going to stay in the house till Thursday. And then everyone was going to come over unmasked, not super long. They couldn't do it. My family. Now I've been doing this for 9 months. They couldn't do it. So Thanksgiving will be me, my husband, and the 3 children I gave birth to. And that's it. I'm not going to feel bad about it. I got catered food going to my mother, my father, my in-laws, my grandmother, and for the medical students that are away from home, I will make sure they're all fed. But if the people don't live in your household, you don't know where they are when they're not with you, and they don't need to be in your house, period. Period. And I can't mince words about that enough. I cannot. So for me, there's no gray area at all. Now we'll have a Zoom and we'll do all that stuff. We'll do it. But in terms of who I will be looking at and hugging, it will be those 4 people, and that's it. So.
Amen. Amen. Greg?
I am going to be spending both Christmas as well as Thanksgiving at home with my husband and our puppy. And we are going to make sure and have a Thanksgiving where we can be on Zoom with the rest of our family. My father is 85 years old. He has leukemia. I can't imagine traveling to New York City on an Amtrak train, even if I isolated and was tested beforehand, risk getting COVID while on Amtrak or navigating through the city on the way to my father's house, only to pass COVID-19 on to him. I was with my mother when she took her last breath, and that was something that was one of the hardest experiences that I know many of us have faced in our lives. I can't imagine having that experience with my father, knowing that I was the one who was the instrument of his death. So I'm going to be staying home, and I'm going to be enjoying my family from afar. I'm going to be loving them from afar, and I'm going to look forward to seeing them next year when hopefully most of this is behind us.
Amen. Amen. Bishop Dr. Horace Smith, you have the final word.
Well, I don't know about the final word, but I want to co-sign what the other speakers have said about individuals. I think in your family and personally, you have to be ultra careful and don't cut corners. At our church, we announced yesterday, we're going to have the biggest food, new coats, toy giveaway than we've ever had. We're going to feed 3,000 families on Thanksgiving and for Christmas with 3 boxes each of food stuff, cleaning materials, and whatever. They're going to come by the church. They're going to drive by, come in and get it. We're going to have 1,000 new coats. We've taken sizes from about 8 shelters, and then for the community, they're going to come and get it. And the kids are going to come to our church with 20 stations, sanitized. We have bought them Christmas bags. They'll come in and be socially distanced. They'll get whatever toys they want and go home. We are not going to let the pandemic in our community make our kids not have Christmas and not have joy. So we're trying to balance on both sides. Personally, we're only our family in our home. But for the community, I think that the church has to stop saying it's an example and a witness, and it can't be creative enough to overcome something like this. We can do this as every church can make a commitment to meet somebody's needs that without it would have a drab Thanksgiving and Christmas. That to me is unconscionable. I told my parishioners, you have to give more the next 2 weeks. We're going to spend $100,000. It doesn't matter, but we're going to do this because this is a special time that we cannot let the enemy capture everything. So that's just my, church to pastor to leader. Be creative, find a way to help somebody during these holidays, which is the essence of them anyway. And I think that we have done a good job.
Thank you so much. Thank you so much to this great panel. I hope you know I'm clapping and giving everybody a hug. This was a wonderful conversation.
Let's get everybody my phone number, they can have it.
Okay,
we can talk.
My phone number, and I want you to know that I'm going to invite each and every one of you to be on a guest on Dr. P on the podcast to keep the conversation going. For all of you who came as participants and hung out with us for the last 90 minutes, thank you so very much. Tomorrow morning, we're talking about the legal impact of COVID-19 on our churches, because there's a legal impact too. We're always talking about the science and the social distancing and wearing a mask, but we have Attorney Tim Muffin, who is an attorney who is really talking about the legal impact of our churches. Be there for the morning session tomorrow morning. We'll see you in the evening. If we don't see you, we'll see you. Be there in the morning at 8:30 Standard Time. Y'all, I ain't got nothing but love for you, baby.
I love you too, Vanessa.
In Gilead. Guess what? I'm out. Thank you.
Love you guys. Hey, be